Good morning, good afternoon, good evening, or good middle of the night. Thank you for taking the time to watch Maternal Mortality, a crowdsourcing evaluation. Today we will start off with a general overview of the issue of maternal mortality as it affects India. We will follow this by a discussion of a project proposal for the Gates Grand Challenge competition. This will lead into an analysis of crowdsourcing as a tool for global health. Specifically, we'll talk about the ethics and efficacy of the Gates Grand Challenge. So please take the time to get ready for class. On education, you will find a link to the Lancet article called Gates' Greatest Challenge, and you will also find our crowdsourcing project proposal. Maternal mortality is the greatest health disparity between rich and poor countries. India is no exception. To provide more context, we would like for you to watch a video which examines the death of a woman giving birth in India.
बढ़िया बढ़िया लड़का दिलम लिहिस उनके चुम्बी लिहिस कन्या लिहिस सब कुछ भवा लेकिन उसके बाद में बच्चा होई गवा नारवार कट गवा चक्कर के बाद कहीं की अभी का मने कहीं बंद नहीं हो रहा बिल्कुल बच जाता ब्लड की ट्रांसफ्यूजन का अगर इंतजाम हमारे यहाँ होता बिल्कुल हो जाता हमारे मजबूरी थी फुल डायल टेस्ट में उसको हम भेज नहीं सकते अगर उसके पास 2 घंटे की टाइम होता उसको सीधा रेफर करते गए तो गेट मैंने बंद रहा तो कहीं मैंने खुलावा जाए हमारे घर के आदमी कहीं खोलो तो गेट वाला जानत का कहीं की हमने डॉक्टर मैंने मना किया है
बस उसके बाद अंदर जब गया था तब अंदर बाहर जब डॉक्टर साहब आए देखने लगे थे फ्रांस
At least 3 checkups are to be done for each and every antenatal patient and we try and convince each one of them to please come to our hospital, get examined and at the time of delivery you come to our hospital. We are very short of doctors, so most of us have to work as maternity doctors, whether we have that degree or not. We have to make sure that we have enough medicines, enough fluids, oxygen, electricity. Electricity is a big problem. Thousands are thronging that hospital. One patient is delivering here, the other one is delivering there. A lot of commotion is going on and we have to manage. We try our level best.
सीधा पानी घर में लड़कन का देखभाल करा रहे तो बढ़ जाता रहा काम। अब घर को देखो यूं देखे परी जैसे मम्मी होते इनकी तो देखभाल करती। अब नहीं है हमरे माथे छोड़ छाड़ के हाँ खत्म हो गए तो फिर हमका करना है ये हम ना कर दे तो वो करेंगे। अरे अब गुस्सा आ रहा है गुस्सा तो हमरे है नहीं है लेकिन अब जो भवा तो ठीक भवा लेकिन हमारी कस गलती अब एक साथ है।
These are the facts. Every minute, one woman dies from pregnancy and birth-related complications. 99% of maternal deaths occur in developing countries, and 1 in 120 Asian women are at risk of dying compared to just 1 in 4,000 women in developing countries. For every woman that dies, 20 survive but suffer from injury, infection, and other diseases. Skilled care, prenatal care, care during childbirth, and postnatal care can save 200,000 lives a year. In India, 70,000 women die from pregnancy and birth-related complications, which is 1/4 of the world's maternal deaths. For a graphical representation of this burden of disease, we went to the Institute for Health Metrics and Evaluation from Session 3. As you can see, South Asia has the highest number of maternal deaths than any other region. Note that this is a number, not a percentage, so the high population in South Asia affects this output. Our submission to the Gates Grant Challenge hoped to combat maternal sepsis, which is in yellow with the text over it. This year's Gates Grant Challenge posed the question, what incites healthy behaviors? What makes people behave differently? And what makes people seek out and use health services or engage in positive preventative behavior? In order to address this question, we went through many drafts of ideas. Our first idea involved cell phones. We hoped to create a personalized calendar of appointments. However, we lacked the technical expertise to make this a reality. We also examined coconut water as a way of preventing childhood diarrhea. However, we were unable to think of a way to make this creative or unique. Similarly, we looked into community programs and women's groups, but these groups already exist, and there wasn't much that we could do with them. Finally, we also considered creating a breastfeeding formula. However, our lack of technical expertise, again, did not allow us to take the next step. In the end, we settled on an integrative method for finding maternal mortality. We tried to incorporate biomedical, educational, and access to care into this program. The program would utilize 3 different approaches to preventing maternal sepsis. The first would be the administration of clean delivery kits, which would help promote the use of the WHO 6 cleans. These cleans include clean hands, clean perineum, clean delivery surface, clean cord cutting, clean cord tying, and clean cord care. We would also include an educational component through a video presentation to community members and a second presentation to community health workers to ensure that they can safely and effectively use the clean delivery kits. Finally, we would like to incorporate a hospital partnership by creating a program that would allow women and health workers to contact a medical personnel in times of emergencies or simply when they have questions. This would utilize the ubiquity of cell phones in the area in India. We hope that the outcomes for this intervention would be improved sanitation during birth, decreased infection rate among mothers and infants. We hope that it would incite healthy birthing behaviors and increase the trust among mothers in the local hospital. In order to visualize the inputs, outputs, and outcomes of this program, we created a logic model. As you can see, the program would incorporate human resources, including medical professionals, clean delivery kits, and would need also transportation. It would only be possible with the participation of health workers, community leaders, women, doctors, and medical staff. The idea for this project to be implemented in India came from the experiences of our group members, 3 of whom have been to India before. One of our members strongly believed that this kind of program would be perfect and very implementable in the hospital that she worked in, which was in Mount Abu, Rajasthan. While we were working on the Gates Grand Challenge, we began to realize that the challenge itself did not seem to focus on sustainable programs, favoring instead quick fixes. Specifically, we saw this in its emphasis on highly technical solutions as opposed to educational programs, and also on its insistence on directly measurable outcomes. Even the Changing Behaviors Challenge framed behavioral change as a problem for behavioral economics, psychology, and behavioral science, specifically mentioning that education was not as important as these areas. Given the increasing popularity of crowdsourcing global health, we believe this trend raises significant questions about the ethics and efficacy of crowdsourcing solutions. As the authors of Lancet's Gates' Greatest Challenge article point out, in calling on the world's researchers to develop innovative solutions targeted to the most critical scientific challenges in global health, the Gates Foundation has turned a narrowly conceived understanding of health as a product of technical interventions divorced from economic, social, and political contexts. In our class session, we hope to examine the successful projects of the Gates Grand Challenge and critically analyze both the accomplishments and shortcomings of these programs. Thank you for watching, and we look forward to seeing you in class.